All right, so we're going to talk about gallbladder disease, including cholelithiasis and cholecystitis. These do fall under our concept of inflammation, and I want to make sure that we talk about this before we get into pancreatitis, because you'll see why there's such a close tie when we discuss pancreatitis. Again, I've provided you with a little diagram about what we're going to talk about here with gallbladder disease. We're going to do an inflammation review as we've done with each PowerPoint, and then we'll move on to our exemplar of gallbladder disease as an inflammatory disease, specifically as we're attacking all these GI issues, and of course some of the topics that will fall underneath that gallbladder exemplar. I don't plan to go over this again. I expect that you'll read it, keep yourself refreshed on this concept of inflammation so that it's sealed into your mind for future classes. So we'll start talking about a little bit of terminology here. Bile, this is an alkaline fluid that's created in the liver and stored in the gallbladder, and its purpose is to digest fats. Gallstones, as you can see here on the right, this is a gallbladder, and it's obviously very full of gallstones, but these are stones that are formed of bile or cholesterol or both. Biliary colic, this is a severe steady pain in the epigastric region or the right upper quadrant of the abdomen that can radiate to the back, the right scapula, the shoulder. And again, just keeping in mind that location of your gallbladder where it's tucked there underneath your liver and the bile duct that kind of comes more to the epigastric region, you can understand why you would have pain in this region. And I just wanted to include this here. This is also another little picture of gallstones down there. I just find this pictures fascinating. Hopefully you do too. So continuing on with some simple terminology, cholangitis is inflammation of the bile duct. Cholelithiasis, which we'll talk about more in depth, is that formation and presence of stones in the gallbladder. And then cholecystitis is inflammation of the gallbladder wall, and it's most often caused by those gallstones. They obstruct one of multiple ducts, the hepatic, the cystic, or the common bile ducts. And again, we'll elaborate on that a little bit further into the presentation. So what is gallbladder disease? Well, normal gallbladder function, and again, you can see here they show how the gallbladder is kind of tucked up there safely underneath the liver. But basically, the liver produces bile. It's stored in the gallbladder for when digestion occurs, and the body needs digestive enzymes to digest fat. And you can see how the bile duct sweeps up out of the gallbladder and comes down here again into that duodenum area of the small intestines, just below the stomach, the opening in the first part of the small intestines. And so along with pancreatic enzymes, you have this bile that's being put into the duodenum to begin that digestive process. Gallbladder disease occurs when the flow of bile through the hepatic, you can see the hepatic duct here, the cystic duct, or even at the common bile duct, that juncture here, that the flow of bile is altered or obstructed. And ultimately that leads to backup in the gallbladder. Most commonly this occurs as a result of gallstones that travel. Less commonly it can be related to tumors and abscesses, but overwhelmingly what we see is gallstones interfering with the ability of not only bile, but other digestive enzymes to make it into the duodenum. I've included a really great video here. It's a little bit longer at 5 minutes, but again, definitely worth your time. Sometimes it's really great to hear someone kind of give you an overview rather than such in-depth study as we're doing here, so that you can proceed on with our more in-depth look with a better understanding of the flow of talking about this disease. So take time to watch the video. The etiology of gallbladder disease basically is kind of founded in this stone formation. And the stone formation is caused by an interaction of multiple factors, but there's abnormal bile composition. Usually there's a higher cholesterol level in those gallstones. There's what we call biliary stasis. So for one reason or another, the bile is kind of sitting in that gallbladder, and those crystals can form just like they do with kidney stones. And you'll learn more about that when you get into your 151 class. And then, of course, there's inflammation of the gallbladder. So that's what happens. The gallbladder becomes inflamed, usually because of these stones and some sort of blockage. So that's the kind of foundation of gallbladder disease. I included this timeline. I wanted to make a timeline because I thought it really was kind of relevant in this context. You can see here that in the beginning that the risk factors come into play, some of our more common risk factors, and then you have the formation of those gallstones, because for one of these reasons or another, there is that perfect combination of abnormal bile salt or abnormal bile composition, biliary stasis, and then the inflammation of the gallbladder. Those gallstones start to form. The gallstones then irritate or inflame the lining of the gallbladder or the ducts. That's called biliary colic, that steady severe pain. And then it ends up that the stones travel. They compile in the gallbladder, as we saw in that one picture in the beginning, or they travel outside of the gallbladder into the ducts and they become lodged, just like a kidney stone would. After that, the bile backs up into the liver, causing pain and jaundice. If it's blocking the common bile duct, it can affect pancreatic enzymes and it can cause backup into the pancreas. So the idea here is blockage, and that's what leads to multiple symptoms that we'll talk about and pain. So when we looked at that timeline, we looked at risk factors first. And I'm going to talk about some of the more common risk factors here. We talk about hormonal, and when we talk about hormonal, we talk about something called the 4 Fs. And I'm going to use terminology here that's not exactly kind, but it kind of helps you to remember it based on those 4 Fs. And the first one is F for female. Women are far more likely to have gallbladder issues than males. And it certainly revolves around this. Fertility, estrogen. So if women are on estrogen therapy or oral contraceptives, that puts them at higher risk. Additionally, so the 4 Fs themselves are female, over 40, fertile, and fat, which is kind of the more derogatory term, but basically obesity. Obesity causes you to store hormones. They are stored in the fat. So again, you have exposure to that additional estrogen hormonal influence. And so that's the 4 Fs. So female, 40, fat, and fertile. And so you can see how all of those can come into play and really make up a high population of the risk factor for this particular disease of gallbladder disease. We already talked about obesity. Another thing that can impact it obviously is diet. So low-calorie liquid protein diets, rapid weight loss, increased red meat consumption, greater cholesterol and saturated fats. Anything that's going to increase that cholesterol or lipid content is considered a risk factor. We have non-modifiable risk factors, genetic predisposition. Again, nature and nurture, nature versus nurture, hard to know. Older adults, as we said, over 40, right? And then gender, females greater than males. Let's take a look at the second slide. Again, under modifiable disease, type 2 diabetes, which often comes with high triglycerides, diseases like Crohn's disease and cirrhosis of the liver. These can impact the potential for a higher risk of gallbladder disease. Being on cholesterol lowering medications, so our fibrates and our statins specifically, can actually put you at a higher risk for this. It seems counterintuitive. Smoking increases your risk for gallbladder disease as well. And ethnicity, so Native or Mexican Americans are at a higher risk for this particular disease. So I put this chart here to kind of compare cholelithiasis, so that gallbladder stone formation, to cholecystitis, which is that inflammation of the gallbladder or the ducts, and often involving blockage. So in both cases, the onset is abrupt. The pain can be severe and steady. With cholelithiasis, it's more localized because this stone formation is just occurring in that gallbladder. And so you may have that localized right upper quadrant, may radiate to the right shoulder, depending on how sensitive you are to that pain. Cholecystitis, however, that can be that generalized right upper quadrant pain, It may radiate to the back, the scapula, the shoulder. These patients, as far as tenderness to touch, they're going to be guarding. Again, realizing that with cholecystitis, now the gallbladder itself is inflamed, perhaps the ducts are inflamed, there may be blockage, which can kind of cause that more generalized feeling of pain and the radiation of pain. How long the pain lasts. With cholelithiasis, if you're going to experience pain, it may last from 30 minutes to 5 hours, and then it goes away. It can be intermittent, so you may go a month or two without it, and then you may have it again. As far as cholecystitis, that pain lasts 12 to 18 hours, so much longer duration of already generally more severe pain. Some additional symptoms that you might experience, you may have some nausea and vomiting with cholelithiasis, much more rare with the vomiting. The cholecystitis, you may have loss of appetite, definitely that nausea and vomiting. We're now interfering with digestion, depending on whether or not there's infection. You may have chills and fever. And again, as far as aggravating factors, with cholelithiasis, diet is definitely one of those. So these people may feel nauseous after eating a fatty meal, like having McDonald's. Aggravating factors for the cholecystitis, it's aggravated by movement and breathing. So again, that movement, that rubbing against the gallbladder that's already inflamed and irritated. So with jaundice, you may see that with the cholelithiasis, probably more likely with the cholecystitis. When those bile ducts become blocked, that bile backs up. There's higher levels of bilirubin in the blood. And so you see that manifest itself as jaundice in the sclera and the skin. You may see clay-colored stool because it's fattier, right? Bile breaks down fat. It's not being broken down. It's coming out in the stool, that steatorrhea, that fatty stool. Additionally, if the bile is not going through the normal channels, bile gives stool its characteristic brown color. So when that's blocked up, the stool becomes more clay-colored. An atypical presentation, so in older adults, they may not have some of the more severe symptoms, but they may experience delirium, and that can be related to infection. And you remember, sometimes our older adults don't present typically, so they don't show a fever. So delirium may be a warning sign with this cholecystitis and cholelithiasis that an older patient is experiencing a gallbladder concern. Let's look at diagnosis. Again, CBC with differential. Always looking at this in these cases of inflammatory and potentially infectious concerns that we're confirming or monitoring inflammation or infection, and we're going to see elevated white blood cells. We're going to look at bilirubin, and you can get that on your CMP. This just shows us, not diagnostically necessarily, but there's the potential for obstructed bile duct. So it can tell us, it can indicate liver injury. It can tell us potential cause and complication. So we're going to see elevated bilirubin. This amylase and lipase, they help us to identify potential pancreatitis, a blockage further along in that common bile duct, elevated amylase and lipase, and remembering that lipase is more specific. CMPs or LFTs, we're going to be watching potential for liver dysfunction. So we'll look at those liver function tests. And you can see over here, they would be elevated, that ALT, that AST, and that ALP. Again, gallbladder disease can also impact electrolytes with nausea, vomiting, diarrhea. So those are some of the things that we're going to watch with the CMP. And then this is kind of a new one here, these lipid panels. Again, this is a causative consideration for the etiology of gallstones. So those elevated cholesterol and triglyceride levels, knowing that gallstones are formed by that abnormal composition, and that includes cholesterol stones. Includes cholesterol. And so what's really fascinating about that is, as we get into talking about management, this is going to make an impact on some of the decisions we make as far as treatment. Again, talking about white blood cells, no surprises here. We've been talking about this all along. We are looking for inflammation or infection. Very real possibility with an irritated gallbladder that we're going to have infection. Bilirubin can indicate a blocked bile duct due to inflamed pancreas or gallstones. And again, when you see the anatomy of this whole situation, you understand how that can happen. So when we look at lipase, we expect that to elevate as well if there is pancreatic blockage. Again, quite a possibility for a gallstone to come down and to block that common bile duct, causing backup into the pancreas. Along with lipase, we might expect amylase to be elevated. Again, can point to a pancreatic blockage. That's one of the pancreatic enzymes. So we might see elevation there as well. This alkaline phosphatase is one of those liver counts that we're looking at. This can occur with bile duct obstruction. And while it's not diagnostic of gallbladder disease, it does correlate that liver involvement so that we know that the liver's in distress. And again, we refer to those lipid panels. I'm not sure if you've seen these in your previous courses of study, but we're looking at our total cholesterol, our LDL cholesterol, our HDL cholesterol, and our triglycerides. And these are the standards for those. So when we have elevated levels, again, not diagnostic of gallbladder disease, but correlating a cause, a potential contribution to gallstone formation. As far as diagnosis, imaging, and procedures, we're going to look at a first-line test, usually the abdominal ultrasound. With this abdominal ultrasound, we can visualize stones. We can see how thick the bladder wall is, the gallbladder wall is, so the potential for inflammation and swelling there, fluid collections that might indicate infection or perforation, and then that dilation of the common bile duct showing the backup. Abdominal x-rays can be used, but this is not a first choice because it's just not as clear and specific. Hepatobiliary scans, a HIDA scan, if the abdominal ultrasound is inconclusive, we're probably going to resort to this. Much more specific, it can assess the biliary duct system because it uses a contrast dye, similar to like we talked about with that barium enema, or sorry, not barium enema, barium swallow, where we, put that radioactive barium and swallow it, and then we watch it go through the system. Kind of the same idea here with a HIDA scan. We're putting in the contrast dye and we're watching it go through the biliary duct system. So we can see what's going on and if there's any blockages and things like that. This ERCP, endoscopic retrograde cholangiopancreatography, this is a direct visualization. It can also allow us to remove gallstones. But again, as we get into pancreatitis, you're going to understand how this can be a potential problem. So not necessarily the go-to. And then the MRI is more when other tests are inconclusive. Again, MRIs are fabulous. They offer great views, very clear, but they are also less common, cost more time consuming, more patient concerns with them. So how do we manage gallbladder disease, cholelithiasis and cholecystitis? So obviously we look at prevention first. Cholelithiasis is that stone formation. We want to be attacking the issue head on at that early phase. And so in order to do that, we're going to manage those risk factors. We're going to think about our 4 F's, right? Obesity, hormone exposure. Not much you can do about it if you want to have 4+ children. So if you're very fertile and you want to have lots of children, it's a risk you take. And being female, there's nothing you can do about. So we're going to focus on this gradual weight loss because we know that rapid weight loss can cause the formation of stones. Regular exercise. Again, having talks with your primary care providers and your OBGYN if you're someone who's at a high risk for gallstones about potential contraceptive therapies. You're going to consume a low-fat diet that's rich in high-density lipoprotein cholesterol like seafood, nuts, and olive oil. And if you're smoking, we're going to encourage you to stop. For acute episodes in the hospital, we're going to make the patient NPO. We're going to give an NG tube. And we're going to try and eliminate food triggering in the gallbladder. Okay, so we're going to try and give that rest, try and relieve the nausea and vomiting. And then we're going to implement, when we do start feeding, some dietary limitations, particularly lower fat. As far as pharmacological, so I'm going to start with these gallstone dissolution dissolution drugs, Chenadol and ursodiol, Actigall or Urso Forte. These are gallstone dissolution drugs. So basically what they do is they break down the drugs. And the way that they do this is they decrease secretion of cholesterol from the liver. They decrease the cholesterol content of the bile stones, and this allows bile stones, or gallbladder stones, to dissolve. Okay, so that's the method of action for these stones, or for these drugs. Very effective. So if people have cholesterol, stones with high cholesterol content, this is going to help them to have stones that have less cholesterol content and allow them to dissolve. As far as the nursing role in patient education, it's, again, as we said, it's most effective on stones that have a high cholesterol count. It doesn't dissolve calcified gallstones, so it can't help with some of the existing stones, and those are still going to be a risk for cholecystitis. Common side effects of this medication are diarrhea, just like any cholesterol inhibiting medications. And adverse reactions may cause you to have to reduce the dose, and that may decrease the efficacy. One of the things that we're going to watch for with these drugs is that they can affect the liver, so we're monitoring ALT and AST for elevations. As far as pain management goes, this can be a very painful condition. I can attest to that from personal experience. We may introduce NSAIDs to reduce inflammation, ketorolac being a prescription form of NSAID. We may even resort to opioids depending on the severity and what's going on. So we may be looking at morphine. As far as nursing role and patient education, we're going to educate them about NSAIDs for chronic and mild moderate pain. We know that when we're dealing with NSAIDs and chronic use, we have a concern for GI bleed. We've talked about that before, moving all that information forward. With opioids, we have a concern for constipation, which is not going to go along well with this particular disease. So those fall under our nursing role and patient education role. As we talk about inflammation and the potential for infection within the gallbladder, we have to consider antibiotics. The top ones that you're going to see are amoxicillin and cefazolin. As far as the nursing role, we know that antibiotics can frequently cause GI side effects. We already have a concern for nausea, vomiting, and diarrhea. And so here we go with antibiotics, and we have a concern that it can aggravate that. Hopefully, if needed, it's going to resolve the issues, and those side effects won't be a problem. With any antibiotics, we're going to watch for adverse reactions or anaphylaxis. And with all antibiotics, we're going to take as prescribed, and we're going to complete our prescription. So bile salts are a component of bile, and they're part of that process to help break down fats. But when we have blockages, so when that flow of bile is disrupted and those bile salts in the bile begin to build up in the blood, sometimes they come out on the skin, and it can cause extreme itching in the skin. And so we may need something like this cholestyramine or Questran, and it's something that binds with bile salts, and it helps to promote the excretion of the bile salts in the feces. So rather than building up and coming out in the skin, it's going to help bind them and get them out in the feces. Part of our nursing role or patient education is that this is used when the bile duct is blocked, right? That bilirubin backs up into the blood, and as I said, on the skin, it causes inflammation and pruritus, which is itching. Side effects from this medication: constipation, nausea, bloating, and heartburn, and it can interfere with absorption of other medications. So again, not completely harmless to take, and you can see that it's has the potential to cause GI side effects as well in a situation where we're already dealing with GI symptoms. As far as management, when we talk about procedures or surgeries, extracorporeal, so outside of the body, shockwave lithotripsy. Just as in the case of kidney stones, which you'll learn about in your 151s, we can use this shockwave therapy to break up stones. This is good for people who are non-surgical candidates of normal weight. Again, obesity can interfere with the ability to effectively break up the stones. Patients should be taught that this is a non-invasive procedure, so it's a good procedure for those who are really not candidates for surgery. It may take multiple treatments, so it may take multiple applications of this lithotripsy in order to effectively break up the stones. And then, of course, as far as your nursing role, you're going to administer those prescribed analgesics as needed for these patients so that they're comfortable going through these multiple procedures. When we're talking about management, particularly cholecystitis and blockages, we're looking at what we call a cholecystectomy. And this is the removal of the gallbladder. It's usually done with a laparoscope. That's the most common way, unless there are complications or contraindications for the cholecystectomy. Obviously, we're going to want to do it laparoscopically. And of course, because of this, we can have patients discharged very quickly. The old way of doing it, and the way that we need to do it when we cannot do a laparoscopic surgery, is an open surgical removal, which is a much more complicated process. This involves a 1 to 2 day hospital stay. And again, you can see I put some great videos here again. Please watch them. They're fascinating. You can see how this is done. No matter where you want to go or where you end up, if you're on med-surg floors, you're going to have overflow. No matter what floor you work on as a med-surg nurse, if you have open beds, you're going to be seeing things that are not necessarily underneath the specialty that you hope to practice under. So please watch these videos, give yourself an idea of what's going on with surgical management of cholecystitis. As far as post-surgical management, with the care of the open approach, you have patients who are going to potentially have a T-tube drain in there, allowing fluid to drain from the gallbladder area during surgery, and that T-tube may stay in. So you're going to be watching and caring for that T-tube and monitoring output. After the open approach, patients, again, this is a more intensive surgery, more invasive surgery, and so there's going to be a gradual resumption of activities. They're going to have a clear liquid diet, and they're going to advance to solids as tolerated. And of course, at this point, the idea of having to watch your cholesterol and your fat in your diet is largely removed because your gallbladder is gone. Because this is an open approach, you're going to take showers instead of baths. Any incisions that are sealed, if they have steri strips on them, we're going to make sure that we allow those steri strips to fall off on their own. We don't take steri strips off. They stay on pretty well, and they stay on until they're not needed anymore. As far as the care for open approach or laparoscopic approach, you want to encourage frequent ambulation. Surgeons will let you know the limitations for any patient following a surgery. There should be orders as far as ambulation, but frequent ambulation for any abdominal surgery decreases the risk for clots. Frequent ambulation for our laparoscopic patients for whom the procedure involves pumping air into the abdominal cavity, it greatly decreases the chance that they're going to have chest and shoulder pain from that trapped air. So we want to get those patients up and moving. We're going to perform incision care. We're going to give incision education, what to look for as far as infection. And of course, because it's an abdominal surgery, we're going to talk about splinting, coughing, and deep breathing. Again, getting those lungs working well so we have no chance of pulmonary embolism, and how to splint the abdomen to protect the incision, and encouraging that deep breathing. We'll talk briefly about complications of cholelithiasis and cholecystitis. Cholelithiasis, or stone formation, can obviously lead to cholecystitis, so that inflammation within the gallbladder, potential blockages in the bile ducts. Again, common bile duct obstruction. This can possibly lead to jaundice and liver damage, right? If we have the stone down far enough that it's blocking flow from the liver, now we have a problem with the liver. If it's down far enough to block pancreatic enzymes from going into the duodenum, then we have pancreatic issues as well. With cholecystitis, we have the concern with that inflammation and infection, that we can have gangrene, and eventually because of that necrotic tissue and the weakened tissue, we have a concern for perforation and that infection entering into the abdominal cavity and causing peritonitis. We can have chronic cholecystitis, so we can have repeated blockages, which is a real stress potentially on the gallbladder, the liver, and the pancreas. We can have empyema. Empyema is just a pus collection within the gallbladder. That's a complication that we can face with this cholecystitis. And fistula formation. So again, with that gangrenous tissue and perforation, we can also have fistula formation. And fistulas are just openings between two areas that should not be connected. So for instance, opening between the gallbladder and directly into the abdominal cavity. The gallbladder is self-contained. It's meant to hold bile. It's meant to push that bile, to take it from the liver and push it into the duodenum for digestive purposes. If a fistula forms between the gallbladder and the abdominal cavity, we now have that leaking into the abdominal cavity.